So there are a few studies that are relatively new in the last few years on cerebral venous thrombosis. One of these studies is ESCOA-CVT, in which we couldn't find a difference on establishing a long-term duration of anticoagulation, meaning 12 months compared with 3 to 6 months. So there was no difference in terms of recurrent events, in terms of bleeding events, and there were numerically higher rates of death and vascular death in patients with CVT, which suggests that there is no early benefit on prolonging anticoagulation. However, this, of course, has to be considered when discussing and making the individual patient decisions on the duration of anticoagulation. This information can be considered, but the decision should be always tailored to the individual patient. Another recent study is the Decompress 2 study. This was a prospective study. It was published in Stroke last year. This is a prospective study on decompressive surgery on cerebral venous thrombosis, including 118 patients. And indeed, the conclusion is that this is a procedure that is associated with good functional outcomes, but still comparing the prospective data with the retrospective data, we could understand that the mortality rates are indeed higher than what was reported in the retrospective data. So there is some reporting bias probably on the retrospective analysis. And so 1/3 of patients still die despite the decompressive surgery. But still, the conclusion is that we should perform decompressive surgery in patients with impending brain herniation. Although this was a study without a control group, we know that the outcome is very deadly in patients that are not submitted to surgery. And what we can see from the results is that either patients die, about 1/3, or very few patients, only 10%, is left with severe disability, so ranking scale 5, which means that we should offer this treatment to these patients because they tend to recover in the long term, even despite the fact that this was a cohort of very severely affected patients with large proportions of coma, midline shift, and all signs of impending brain herniation. Still, the outcomes, the functional outcomes in the long term are quite good. And after 6 months, 1/3 of patients achieve functional independence. So that is another important recent study in the last years. Another important study was DOAC-CVT. It was published this year on Lancet Neurology. This is a study that was observational, that was assessing patients with oral anticoagulation after CVT, comparing vitamin K antagonists and DOACs. And indeed, the conclusion is that DOACs are safe and effective in terms of preventing recurrent events and bleeding events. And so this adds to the previous data on the use of DOACs in these patients. There was a randomized controlled trial and also some retrospective cohorts. The randomized controlled trial, the largest one, is the RE-SPECT-CVT study, which was the first study assessing the Aguiar trend or VKA in patients with CVT, and the conclusion was the same: similar rates of bleeding, similar rates of thrombotic events, similar rates even of recanalization, and also some retrospective data that was also published recently from the US group, the Action CVT group. So we do have now quite a large set of evidence that can help us to decide on the use of DOACs and in general to manage anticoagulation in these patients, duration of anticoagulation and decision on the type of anticoagulant. We were also presenting at ESOC a sub-analysis of the DOAC-CVT study, assessing also recanalization rates in these patients. And actually, the rates of complete recanalization were a bit better on BKAs, But I think the most interesting is that we found, even after controlling for other predictors of outcome, an association between venous recanalization and functional outcome, which was something that was still lacking this more robust and analysis on a large data set of prospective data. So I think these are the main new studies that have been published and presented in the last years, and indeed this adds to the evidence that we have on the management of CVT patients, especially these acute treatment decisions and also the long-term decisions on management of anticoagulation for secondary prevention of thrombotic events.